innovations. We do have a very packed schedule today, hence why we are getting started as people continue to trickle in. Please make sure as a participant that you remain on mute throughout the session today. If you do have a question, please include it in the chat box. We are looking forward to a great session today. We now have 67 participants. We did have over 300 people register for this session. So there's really been overwhelming interest for the topic, which is very exciting. To begin, I wanted to briefly introduce myself to put a name to the face, or a face to the name in the emails that you've been receiving from me. I'm Becca Kirby, and I'm a research assistant professor at Northwestern University. I work for NEST360 and have worked with our partners at UNICEF to develop the 16 newborn target product profiles, or TPPs, which you'll hear more about today as we begin the process of developing a target product profile for a retinopathy of prematurity, or ROP imaging device. And I really love seeing some people in the chat for saying hi and where they're coming and joining from us today. Please feel free to continue doing that. It's a great way to see that we have ROP experts really from around the globe who've registered for the session today. So to briefly highlight the agenda, we're going to begin with an overview from UNICEF on the TPP process. We're then going to have 3 speakers from India, Africa, and South America present on the various imaging devices that are currently being used for screening in country, and hear from them on what the ideal device would be. Then we're going to hear from 4 product developers on their innovations and the challenges that they face in development. We're then going to have our panel, which will be moderated by Professor Claire Gilbert and Aisha Malik. And we're going to conclude with a summary of next steps on the TPP survey that's going to be distributed to participants after the session today. So throughout the session, we are going to be conducting Zoom polls for engagement. So when the Zoom poll opens, the question is going to pop up for you as a participant to select. So I'm going to start by opening the first Zoom poll. We will be discussing the responses to these questions at certain intervals throughout the session today. So the first Zoom poll question has been launched. Feel free to answer it over the course of the next few minutes, and we will be discussing it later in the session today. So to begin, we are honored today to have with us Christopher, who is the Chief of Product Innovation at UNICEF, here with us today, who's going to present on UNICEF's target product profile process for product innovation. Christopher, I am now going to pass it off to you.
Thank you. Yeah, so I sit at UNICEF Supply Division leading what we call product innovation, which is about driving R&D and scale of new innovative products to address the needs of kids. Oh, I've got some sound in the background, if you can mute.
Christopher, I just asked you to unmute. I've muted all, so you should. Perfect.
Oh, am I back?
Yes, you're back. Thank you.
Okay, thank you. Yeah, so what I was saying was that I'll be talking about how the role TPPs plays in this process of product innovation, and then how it relates, or indirectly through this, how it relates to the effort we are about to address today. Next slide, please. Good. It's not changing on my screen. Is it working on your end?
It's showing product innovation ecosystem on my end. Is that the slide you want, or do you want the next one?
No, it's the right one. I think it's just my computer reconnecting. No, I'm good. Okay. Good. Excellent. But that's, my camera probably disappeared, but it's reconnecting. I'm still here. So product innovation, as I said, is about driving R&D and scale of new innovative products to improve the lives of kids all throughout the different areas that UNICEF work in. Our fundamental approach is what we call a need-driven approach, where we identify unmet needs in the field, i.e. areas where a product could help address an issue or where the current product procured is not good enough. Once we've identified such a need, we go out and scan the market to see to what degree there's products out there that can meet this needs. If there are products out there that can meet it, we shoot the project straight to scale, which means we take it into the catalog. We do the tendering, including the catalog, and does all the work around driving demand and implementation, including producing guidance, policies, and working with our country offices to influence governments, not the least. If there are products out there that haven't been appropriately validated, we undertake field trials of this, where the underlying notion is that we don't do any efficacy nor any effectiveness. We do the appropriateness side of things. So we rely on established frameworks for the approval of things. And then we look at to what degree it works in the context that UNICEF is operating in. If there are no products available, we create a TPP, a target product profile, and I'll get into in a second what exactly we mean by this. And then depending on the risk-reward profile seen from the perspective of businesses, we'll work with different ways of incentivizing this innovation, ranging from saying, hey, here's the TPP, and once we see something that's good enough, we'll trial and then scale it, to at times also issuing full-blown market guarantees, i.e. we go in and say that we guarantee a certain offtake as a way of incentivizing the R&D in it. Importantly, we are not, even though we procure for $4.5 billion a year, or it's going to get a lot higher this year, we are not sitting on money like this. So we have to go out and find the donations elsewhere in order to undertake this. Next slide, please. Good. So if you look at identifying the needs, this is one of the big challenges we always have. We try to really emphasize this aspect of the need-driven approach, take that very seriously. We get inquiries every single day from companies or innovators that have a product that could help meet the needs of kids. But we don't want to be run by the products, even though some of these I'm sure are great. It's a big effort to do all these things I just outlined, even to put a product in a catalog, it's a year-long effort. So it's not something we just do. So we really always try to start with an appropriate understanding of the needs seen from the field perspective, and then work backwards from there. We often combine it, once we've identified these needs, with we try to always combine it with a so-called business case, by which we mean understanding the size of the matter, maybe the payment willingness to ensure that there is a cost efficiency in it, the route to market, who is the buyer, et cetera, so that there's a good understanding of what will be the implementation side of this product. So we aren't just emphasizing the technical, which we know is only a part of the challenge, right? If you don't understand what the business side of this, it's not going to go anywhere. So we really try to ensure that we emphasize this, both so that we can use it in our own prioritization, but equally so that we can communicate to the innovators what the situation is. Next slide. The TPPs have played a huge role in driving this need-driven approach. The first TPP UNICEF created was back in 2014 for automated respiratory rate counting. The way we like to think of TPPs is that they describe the desired performance rather than the specs. So I often use the respiratory rate counter as the example of this, where we said we want an automated respiratory rate counter that can function in a low resource setting, i.e. be energy independent and be used by someone who is enumerate and illiterate, et cetera, et cetera. We don't claim to be the experts on how to address that. So we then had multiple different approaches to doing this respiratory rate counting that are significantly different in how they approach it. So in essence, a TPP is about describing these desired performances that the product is supposed to solve, and then through that help, what we say industry, but industry innovators. It can be anyone, it can be an NGO, it can be an entrepreneur, it can be a university, to make the trade-off decisions on developing the product. So you're constantly making decisions when you're developing the product. And that's really the essence of a TPP, i.e. to guide on this. Next slide. During the R&D phase, we, as I said earlier on, are not directly engaged. So we like to say we're an innovation function that neither does innovation, nor do we invest directly in innovation, i.e. if we provide money, it's for either the pull mechanisms or field trials. However, we are active in the sense that we engage in discussions around TPPs to clarify questions, to realize maybe there's things we haven't done in the TPP in the right way and update the TPP. So many of our TPPs have been updated many times. We also at times create industry consultations to ensure appropriate communication and for the different actors, innovators to meet and potentially partner around it. And then we eventually, if things go well, we'll do the procurement, the trialing, and so on. Next slide, please. And this is then the last one. So scale, I think most people will agree that the biggest challenge in innovation for development or for humanitarian purposes is the scale aspect of things. This is a huge challenge. Fundamentally, I think the biggest challenge we're all up against is that we in many ways are innovating for customers that don't exist. The big funds, the Glavy Global Fund, these funds do not take in more commodity as a standard unless it fits straight in within one of their areas. So we are really relying on governments to be the one paying for these things, possibly with donor money behind it, but it's often hard to find additional resources. As such, we try to put a strong emphasis from the start of the project to understand who the buyer of these products will be and the money available they have, and always remind ourselves and the innovators that in these resource-scarce environments, the competition for resources is significant. So you have to have a very strong value proposition with the product you come with in order for it to be scaled. Otherwise it shouldn't be scaled. It's very important that we think of that when we're allocating resources to a new product area, we are principally taking resources away from other areas, like whatever it might be, health, nutrition, what have you. And as such, it has to have a really strong offering. We put a lot of emphasis in understanding this aspect and realizing the challenges that are around these things. And then we use the capabilities we have as a convener and as an influencer. So you can argue our strongest capability is being a trusted advisor to governments in combination with the ability to convene actors, including money around it, to advise on which products should and should not be scaled. Again, to really emphasize this aspect of the value proposition that products have to offer in order to be suitable for these environments. And then we also use what we have in our procurement capabilities in order to drive down pricing, so to drive up competition, and as such commoditize the product, thereby over time making it a standard intervention. That's always what we will go for throughout. That is it from my perspective.
Thank you so much, Christopher. And I would really just like to say how wonderful of a partnership it's been working with you and your team in the supply division at UNICEF to develop the newborn target product profiles. So next, I would like to introduce the moderators for our panel discussion today. Our first moderator, Professor Claire Gilbert, is really the one responsible for bringing all of us here together, this incredibly impressive group of leading global experts in ROP on this webinar today. So Claire co-directs the International Center for Eye Health at the London School of Hygiene and Tropical Medicine, and her work has received countless awards and international recognition. As everyone who meets her, I think, knowing that she has a lot of the connections on this call can attest to, she truly is an amazing person with an inspiring passion for retinopathy of prematurity and preventing blindness for children in low and middle income countries. It's also been an absolute pleasure of mine to work with Aisha Malik, who's a consultant pediatric ophthalmic surgeon based at the London School of Hygiene and Tropical Medicine at NHS. Aisha has worked to strengthen ROP services in countries around the world, and she leads jointly with Professor Claire Gilbert the Retinopathy of Prematurity Network, which is funded by the Queen Elizabeth Diamond Jubilee Trust. So I'm now going to pass it off to Claire and Aisha to provide a little overview of the panel today.
Thank you very much, Becca, for those very kind words, and welcome everybody, wherever you may be, to this exciting webinar. It's a great pleasure for Aisha and I to be moderating this. You should all have received a link or an attachment which gives the details and short bios of each of the panel members. And really, I think we've got a fantastic group of individuals who are going to be sharing their experiences, not only people with vast experience of providing services for ROP in low and middle income countries and training and trying out new technology, but also those individuals who are at the cutting edge on developing innovations for imaging in ROP. So I just want to thank you all very much for giving your time, and people who want to know more about each of you, then they can have a look on the short bio. So back to you, Becca, because I think there's now another poll.
Yes, so right now we're actually going to close the initial poll question, and we're just going to share the results so that everyone can see. We did have 79% of participants take this poll, and I think it's very exciting to see we have quite a contingent from Africa represented here today. We also have some representation from Europe and North America, and thank you to those who are representing Australasia, Central America, the Caribbean, South America, South Asia, and Southeast Asia. The other thing that's exciting to see on of our participants who have joined so far today is everyone's role and involvement in retinopathy of prematurity. So it looks like we have 72% are clinicians or healthcare professionals on the line today, which is great because that really transitions well into the first part of the speakers who we will be hearing from today. So Claire, I'm going to pass it back off to you if you want to say any words about our country team, and then we can quickly transition over to Anand.
I think we can just move straight on to the speakers, actually.
Excellent. Okay, Anand, you're ready.
Thank you, Becca, and thank you, NEST, UNICEF, and the London School, Claire especially, and Aisha for this opportunity. So I'm just going to stick to the template. Next slide, please. So I'm going to give you the India and countries around experience. I have no financial disclosures. Next slide, please. Well, India has the highest number of preterm births in any country. We have about 3.5 million. When we started this telemedicine program using these cameras about 14 years ago, we had less than 50 ROP specialists. That's probably gone up to about 250 right now. So it's really less for the number of babies who require to be screened. Next slide, please. So one has to sort of bridge the gap with technology. And next slide. Well, we started off with what most regard as the gold standard, which is the RetCam from the family of Clarity, which is now recently bought over by Natus. This RetCam 2 and RetCam 3 were in about 3 or 4 institutes, but the RetCam shuttle that came to India in 2007, I believe we bought the first one in 2008. And our model from the beginning involved training non-physicians. So one of the questions was who can use it and how easily. So trained technicians, nurses, optometrists, ophthalmic assistants, and that's a CADA under the government. These were the people whom we were training to use these devices, not just to use them in the outfield, but also to grade these images on site and then hook up these images into a telemedicine platform. We've also trained a few ophthalmologists who don't have the luxury of technicians, and pediatricians, some interested ones, are also getting trained. Next slide, please. Then in about 2012, 2013, we had an academic partnership with a Bangalore-based company, and you'd hear from the CEO later, Forus Health. And along with a funded grant from the government of India's Department of Biotechnology, this device was developed. This is, as you can see, it's much smaller, it's much more portable. We'll compare it, but this is the device that is now currently being more widely used, and that's going to be, I think, the focus of this presentation. Next slide, please. And well, there are other than these two cameras, there are camera systems. So they're more like adapters. Things that can hold on to the regular mobile phone. And then, as you can see, this one's called the MI RetCam. They've published their initial work. It's great for photo documentation. It uses the 20D, so it is you have to have a small learning curve, and in the hands of the healthcare worker, it's yet to be tested. Next slide, please. There's just another camera which almost works with the same principle. Again, it's called the C3 camera. It comes out of northern India, Ahmedabad. Again, it uses the 20 diopter and uses any smartphone. And you can basically play around with the working distance to get an image. And that's the image that they've compared of the Neo with their own image using the 20 diopter. Next slide, please. So, well, here's the comparison, and then I have one final slide on the wish list. Well, the resolution is out there for you. And again, this is the RetCam shuttle, because that's the portable version that is being used now for telemedicine. The Neo has a slightly higher resolution. And because, as you can see, it's a square sensor as against a rectangular sensor of the RetCam. And this is an added advantage of the Neo, because you get a circular image and you get slightly more field of view of the superior and the inferior retina as well. Whereas in the RetCam, we're all used to the rectangular cutoff from the superior and inferior areas. The MII, or the MII RetCam, and the C3, again, they're limited by the lens that you place at the end of the adapter, and of course the resolution of the phone, and therefore the field is also limited by that. Again, I would say there's a learning curve in the other two, because it's just like using a 20 diopter, only making it slightly more difficult now, because you have to place your hand on a baby, and then you have to move the working distance. So I've tried both. They are definitely usable. They're great for photo documentation, but there isn't any straight away any integration with the telemedicine program, because that's really what we want, where these images directly come off the device and go into a telemedicine system. My last slide, please. And this is really the wish list. I've put them all down here without any animation, so you can go through them in any order. Of course, it has to be wide field. The resolution has to be good. And by this, I mean for almost all pigmented fundi, especially the avascular retina. It's great to pick up. It's easier to pick up the ridge, the fibrovascular proliferation. It's not that easy to pick up just immature retina. So that's where, the test is. Of course, it has to be portable. I would love some device that just works out of a mobile phone, integrated with a smartphone, or be the phone itself. We should have some zoom capacity, an angiogram unit, and to this I must add the Neo, the new device of the Neo HD is now being tested in a clinical study at our center, which has the FA unit. Small pupil would really help in universal screening. Battery operated, I said, because when you go to the rural areas and there are power outages, battery operated really seems to help. Integrating it with AI systems and telemedicine platforms, and of course, the thing that we all want, it to be affordable. I don't think the word cheap is a good word. I think it should be cost effective and affordable. And thank you. That's my presentation.
Thank you very much indeed, Anand, and sharing with us your real wealth of experience and with using all these different devices. I just want to say that we'll be taking questions at the end. So if you have questions for any of the speakers, please put them into the chat, and then Becca and the team and we will be looking at the questions that are coming through, and then we'll address those right at the very end, once all the speakers have had a chance to speak. So we're now moving on to Nigeria, to Africa, where Dupe Ademola Popolupa will give a presentation on her experience in Nigeria. So Dupe, over to you.
Dupe, I think you might be muted.
Yes, I think she is muted.
I think Dupe needs to unmute just now, if you can. I think the other thing I just thought I can just take the opportunity to say is that the second poll has also opened with questions 3 and 4. So for everyone who is participating, they can also answer their questions 3 and 4 in the poll as well, and we'll present those answers as well later on.
Dupe, I've just asked you to unmute. You see that pop up on your screen, you can click the unmute button and then you should be able to speak.
Thank you so much. Can you hear me?
Yes, we can now, Duve. Thank you so much.
Sorry, unfortunately, my screen just became blank. So I was not able to control the mute. Thank God it came up again. Good afternoon, everyone. Thank you so much for the invitation, Claire, Aisha, and everybody. I want to say that the most important thing I would like to say here is that imaging for retinopathy of prematurity, for those of us in Africa, wherein there are 9 out of 11 countries with over 50% premature birth reside in Africa. I want to say that imaging, camera imaging for ROP screening is a health and wellness issue for ophthalmologists and their team members. It is the easiest and the most comfortable on the baby. It should not be so hard to access or use. And so my contribution here today, this is the most important slide as far as I'm concerned, is that whatever anybody is going to do to make it accessible to us will be very much appreciated. The current state of ROP imaging in Nigeria, and I dare say to most parts of sub-Saharan Africa, is that most people use the indirect ophthalmoscope. And the effect on the neck
JP, can you try switching your video off to see if that will help the bandwidth?
Unfortunately, my screen is blank, but can you hear me?
Yes.
Okay, thank you. I'll just keep speaking. So in some hospitals, we have the digital indirect ophthalmoscope available, while in a few places, the smartphone is available, but most people only just use it to take pictures not as a primary tool for screening. In a few of our hospitals in sub-Saharan Africa, very few, we have wide field camera available. And in most of these places, they are used by the clinician. The next slide that I want to show is to show the image as taken by the smartphone. You can see it's able to show the staged ROP, but it's not comparable to the next image that shows a wide field camera image of a child with ROP. And so we're looking forward to having the device that is wide field, that is able to take good images. Now, what do we think an ideal imaging device is? To get to this, I reach out to my colleagues across Africa, not just Nigeria. And what we believe is important for us, we want something that is low cost, preferably not more than $1,000 for the institution, not even for individual. And of course, we know that this is possible with smartphone, but the challenges that have been highlighted on this table will make it not our first option. We want wide field camera, which is way too expensive. Even the one that is less than, the one that is that has just been discussed by the previous speaker. The smartphone has a relatively steep learning curve compared to the wide field camera. Why the wide field camera has a wide field, just as you can see from the images that I showed before, the resolution in zone 2 and 3 is typically better with a wide field camera compared to the smartphone that we use. The smartphone is easier to maintain, whereas the wide field camera is much more difficult, especially from the technical aspect of it. It breaks down. Shipping alone could cost $450 to the next country. It should be portable, not bulky. It should be handheld. We also want it to be safe on the eye, and we believe both are safe on the eye. We want it to have long span of power supply and adequate memory so that we can store images and be able to refer back to those images. In addition to all this, we're looking forward to a device that is driven by EMR so that it can be integrated easily, or we should be able to easily transfer image for teleophthalmology, be able to compare the images from visit to visit and allow professional chat group, because we do a lot of this. and preferably a non-mydriatic camera. My next slide says the IGROP imaging device is one that is wide field and is universally available, affordable, accessible, easy to master, maintain, and move about, integratable with existing system in our hospital, intelligent enough to at some point be able to say, this is even ROP, intuitive, non-contact, and non-mydriatic. I want to thank all my colleagues. You can see they are here. We form 51% of people who are logged on onto this call. And I want to specifically appreciate the ones on this slide, from Sarah Titati to Tukumba Obajolo. Thank you very much for inviting me over. Thank you.
Thank you very much, Dupe. And I just want to say what a fantastic work you and your colleagues in Nigeria are doing, and how you're expanding services so quickly in such a short space of time. And given the limitations of shortage of ophthalmologists in the region, imaging really, I think, is likely to play an even more important role than in other regions. So the last country panelist is a dual presentation from two colleagues from Argentina. So over to Guillermo and to your colleague. Thank you.
Hello, everyone. Claire, can you hear me?
Yes.
Okay, hello from Argentina. Thanks to the organizer for the opportunity to show this smartphone project in ROP. Next slide, please. I have no financial disclosures. Next slide, please. We will show you the concept of a smartphone hands-free indirect ophthalmoscopy imaging device using the binocular indirect ophthalmoscopy technique. It is currently used for training to residents and fellows, and it could be useful for training clinicians, nurses, and ophthalmic photographers. Next slide, please. We presented a hands-free prototype at ARBO. The flexible arm allows to adapt the working distance of the lens used and the observer's arm's length, and you can adapt the device for registration in the incubator. The smartphone screen is used exactly like the binocular of bio. Next slide, please. At APOS, we showed the potential benefits of building smartphone telemedicine networks in Argentina, teaching in steps, first with a simulation eye, then practice in the office, first with bigger babies, and finally with smaller premature babies at the NICU and follow-up office. Next slide, please. The advantages are the following. It is a non-contact method with the same technique as bio, wearing face mask, the portability and integration with electronic health records networks through smartphone apps and internet connectivity, the sustainability, the ubiquity given by smartphones and internet connection, and the issues to work on are validations and formal teaching programs, which are still required, and we are working on that, and some security and confidentiality and affordability issues. Next slide, please. Regarding the validation of smartphone images, a Latin American regional team from Colombia, Mexico, Venezuela, Chile, and Argentina are currently working in the telemedicine diagnostic evaluation of smartphone images versus clinical evaluation in Latin America. We presented this year at ARBO the first 100 cases of a total of 471 cases. Next slide, please. The validation is focused in the previous. The validation is focused in decision-making algorithm promoted by Pan American ROP Society, which considers zone, stage, and presence of plus, no plus. We found a preliminary accuracy of 83% for type 1 ROP, 81% for type 2 ROP, and preliminary accuracy of 84% for stage 3 ROP. Anyway, many variables will be included in the complete final analysis, like notch and presence of hemorrhages. This work is finishing very soon, and we have included data of quality of smartphone images and the environment to show the impact on the final results. Next slide, please. devices and in networks, artificial intelligence integration with many tools. And we are currently working with APEC Mexico and Microsoft Azure Philanthropics project for vessels evaluation of the continuous severity of vascular changing of all types of ROP images, including smartphone. The 5G and high-speed internet is another ideal state for smartphone real-time streaming for telementoring from NICU. And the use of international standards, we are working in the integration of validated smartphone images to die compact services and on the taxonomy of decision-making algorithms, and the ICROV3 definition is no MedCP clinical terminology standard. Next slide. Big thanks to the Pan American team. Hopefully together we can develop more tools to connect health services in care of prematurity and ROP. Next slide. And here's our contact data. Thanks again for this opportunity.
Guillermo, thank you very much indeed for that quick go through your presentation. And we really look forward to seeing the full results of this important comparison study that you're undertaking. So thank you very much. So this ends the presentations from the country panelists. And I'd now like to hand over to Aisha, who will go through the poll questions 3 and 4.
Thank you, Claire. So yeah, we had the poll running in the background there, and question 3 was, what is or are the greatest challenges you face with respect to the screening devices you use? And this was a multiple choice question, so you could take as many as you wanted. And not surprisingly, the most important challenge came out as cost. So with nearly 60%, giving cost as the greatest challenge. And then quite similar were training and image quality, which were both around 30%. And then just under that was ease of use and infrastructure. So things like internet connectivity, etc. So they were both about 15%. And then there was also other challenges which people haven't listed, which was around 15%. So cost, training, and image quality, I think, were the top 3 challenges there. And then the second question was, what device are you currently using for ROP imaging and screening? And again, this was a multiple choice question, so you could answer more than one. And again, as expected, the most common device was the indirect ophthalmoscope. That was at 68%. And then that was followed a bit lower at 15% by the RetCam, which was the second one. And then subsequently, both the Forus and the Phoenix Icon camera, and also the smartphone, which was around 17% as well. So the top one there was the indirect, followed by RetCam and smartphone with image capture. So they were the top 3 there. So thank you for completing those polls. And I think we'll be also having further questions, which will be popping up as well. So I'm now going to sort of move on just to our product developers. We're really very fortunate today to be joined by 4 global leaders who are developing and testing technologies and AI for ROP. I'm going to, again, their bios are up on the screen, and we've also sent them to you all so you can take a more detailed look. But without further ado, I will hand over to Casey, who is going to be our first speaker in this. Thank you, Casey.
Thank you so much, Dr. Aisha, Dr. Claire, and Becca for giving us this opportunity. So I'm going to talk about how do we create the most affordable and advanced wide field imaging device, the Trinetra Neo and the Trinetra Neo HD. Next slide, please. So Dr. Anand spoke about the Trinetra Neo. We already have the Trinetra Neo successfully across 220 plus installations across 20 countries. The product is a formally US FDA, CE, Health Canada, and many more approvals. So it's a perfect medical device. It's meeting all the regulatory requirements. So you need to build something like that. We actually have been working on building a large-scale platform, not only for ROP, but for diabetic retinopathy refraction. And we built this digital platform over the last 4 years. And we have more than close to about 3 million transactions on the platform, and it's so rugged. And the ROP module is one part of that. So it offers the entire versatility. And more importantly, this platform is completely safe from the cybersecurity standpoint. So it's 27001, 27017, 27018 ISO standards approved. And it is also HIPAA compliant. And we continuously monitor ourselves on the GDPR guidelines. So we have a very, very rugged, which is working platform, which is working across, very remote villages, as well as, in sophisticated cities. So it's a very rugged platform. So it's got a comprehensive tele-ROP platform. Dr. Anand already talked about, but we're very excited. We just launched the Trinetra Neo HD. The first commercial sale already happened. And this is probably the most advanced product as we speak in the world today. It's got a 150-degree field of view. It's a high resolution compared to what you saw on the screen from Dr. Anand. This is a 20-megapixel camera, and it's also integrated fluorescent angiography. So all you ask for is available there. And obviously, it's affordable as we continue to make affordable products. And then given the platform has already integrated AI for DR and macular degeneration and dry eye, we are actually going to add the ROP component to that, all of that built by ourselves, hopefully by December 21. So this will make it the most, you have the device, you have the platform, and you also have AI. So it's going to offer the end-to-end solution to the customer wherever they are. So that's the innovation side of it. The next slide, please. So coming very specifically to the developmental challenges. See, one of the critical thing is our product is probably one of the lightest. It's like the probe is just 340 grams. So you need to have optics fitting into the form factor. So you need to actually create some of them. We have also created custom optics. So it's very, very important. Now, the other important challenge is that we were the first to integrate illumination and imaging together for an ROP device. So earlier it was separate. So then how do you actually kind of take care of the glare and manage all of that? That's the second biggest challenge. But I'll give a high priority to the last one, which is the repeatability in manufacturing. Because end of the day, we are creating a medical grade product. It has to produce device after device, year after year, not have service issues, should comply with all the EMI EMC standards. It should actually work with a platform which is very, very cybersecurity. So manufacturing a product and actually having a manufacturing setup, which has got the highest level of 13485 MDSAP level of manufacturing capability, I think is a very important point. And that, especially given the product is very complex. If I look at what is the challenge from a technology standpoint, right? What we are trying to do is we're trying to illuminate a large portion of the retina, which is 120, 130, 150 now, using a very small aperture. And we'll have to capture the reflections using the same aperture. So that makes it very, very complex. So, when you increase something, you lose something. So you'll have to kind of manage that very effectively. And that's, I would say, the biggest challenge. And fortunately, we were kind of able to achieve that. The future, what we see is trying to come up with transplanar illumination of the pupil from inside so that we build a non-contact wide field imaging system. So we have already tried attempting that in the adult side, and slowly, maybe a couple of quarters or years, we'll try to come up with something like this for non-contact for ROP. So thank you very much for the opportunity, and looking forward to your questions.
Thank you, Casey.
Thank you very much. Yeah. Yeah, Becca, go ahead. Yeah.
Peter, we would now love to hear from you as the next developer panelist.
Awesome. Well, thanks so much, Claire and Aisha and Becca, for putting all this together. I'm going to talk a little bit about the work we've been doing on AI-assisted screening. Next slide. 2 points I'd like to make on this slide. One is that I work with a really awesome team as part of the IROP consortium, and this is really teamwork that couldn't be done without all the people on this slide. Second is that I do, as a disclosure, consult for a company that's licensed this technology from our universities. Next slide. So when we think about artificial intelligence for ROP, we think about that in sort of one umbrella, but it's really lots of different ideas that we can talk about maybe in the discussion. There are many different sort of indications for use for how this might get incorporated in screening. But what we did is developed a ROP classifier that classifies plus disease based on a reference standard diagnosis. So it takes an input image and outputs a diagnosis of no plus, pre-plus, or plus. That was the first thing that we developed. Next slide. But then realizing that plus disease is really more of a spectrum than a binary category, we converted those 3 probabilities into a vascular severity score. That is, you take an input image and you output a score from 1 to 9. This aligns nicely with an updated ICROP 3, which acknowledges that pre-plus and plus run a spectrum. Next slide. We've then validated that several different ways, comparing the vascular severity score that you get from a single posterior pole photograph and shown that it correlates with zone, stage, plus an extent of stage 3. That is, a single photograph corresponds to the whole overall severity in that eye. The second is that it can be used to monitor disease progression over time, identifying those babies progressing towards treatment requiring ROP. And you'll notice this is a US population, so the post-menstrual age may be different in different parts of the world, but you notice that the curves start to separate, up to a month or so before babies end up getting treated. And we have new results we can talk about in sort of how this might play into risk modeling. Next slide. But for the purposes of this call, it only matters if it's effective in populations where it's most needed. And so we partner with the Yerevan Eye Hospital, Parag Shah, and Narendran Venkatapathy, and looking retrospectively at a real world telemedicine program. This is 1,253 babies. We found that it has a high diagnostic accuracy for the detection of plus disease or treatment requiring ROP in this population. So it shows that there's potential for this to be a solution. Next slide. Challenges. So at the bottom is a figure from a paper we wrote as part of the American Academy of Ophthalmology AI task force, looking at how do you move from a great idea to a realistic real world solution that leads to fewer people going blind. And we proposed the framework of implementation science, starting with published papers suggesting efficacy to demonstrating real world effectiveness. And I think that's where we are with AI for ROP, but there are a number of steps to go in terms of making it, implementing it and making it sustainable and scalable. First is this technology only works if there's existing or newly developed telemedicine infrastructure, and that's lacking in many parts of the world. The technology has been validated so far on RetCam. We now have data that it works on the Forest camera as well, and we're evaluating it on other lower cost camera systems. Regulatory approval is a new beast. Getting a hardware device approved is one thing, but getting a software as medical device approved in each of these different regions is going to be a problem that has not yet been solved. And finally, there's the question of who's going to pay for it. How do you add value? How do you get companies interested in a way that's sustainable for them in order to provide a product that really improves outcomes? Almost inevitably, this is going to require governmental support, because in no parts of the world can ROP care exist sort of without that. So I think there's a lot of problems to be solved. Next slide. Thanks so much.
Thank you very much, Peter. That was a fantastic talk. And just now going to hand over straight to Dr. Paul Chan. Thank you.
Great. Thanks so much, Aisha, Claire, Becca, and also UNICEF and Christoph and NEST360. I think that this is a really complex discussion, and it's been great hearing all the speakers, especially from the in-country experts. Next slide. So I'm going to talk a little bit about, this is a good transition from Dr. Campbell's discussion around AI. When we talk about integrated solutions, we talk about AI, we talk about advocacy and all these challenges that we face. I'm going to speak about some of the things that we've been focused on, just from my collaborations with our international partners. One of them specifically involves something that Dr. Dupé mentioned, which is this sort of telemedicine, this integrated solution. And I know Casey mentioned the forest system. What we've tried to do was build out these data management and telemedicine tools that are relatively agnostic to the actual hardware, right? And I think that that's important as we go forward, that we're able to use platforms that can be used across all systems, right, to make it for ease of use. So in addition to the work that Dr. Campbell's done with Aravind, we've also built out this Untitled system, which is a reading center and a data management tool that they're using across their entire system at this point. Why is this relevant, right? And what we've shown is that data matters. So when we look at AI, when we look at technology, when we look at advocacy going forward, we need data, accurate data to use in order to define who's at risk for developing ROP and to show the key stakeholders what's happening, right, in an accurate and organized way. And that's what we've done here with this intelligence system. Coupled with that also is this idea of, we talk about cost effective, as Anand Vinakar mentioned, affordable, right? And what does affordable mean? Wide field imaging systems. And, I've had the opportunity to work with, really fantastic engineers, Dr. Shin Chen Yao and his group, and Devram Toslik and Tang Sun, in building out these cost-effective imaging systems. Now, what's different here is the Illumination Platform. So this is a transparse planar illumination system, which you can see here gives you very, very wide field images, almost out to the Ora Serrata. Next slide. Having said that, as many of the speakers have mentioned, there's still a lot of challenges. With the hardware itself and the transparse planar system, we're still in the development phase, and we have to make sure that it can be clinically validated, that it's easy to use, that it can be useful on the ROP patient, right? Which again has its many challenges for those of you who screen these children. For all of these systems, including the data management tools and telemedicine reading centers, we need to have good infrastructure in the regions. And one thing that's important, when I say this a lot, setting up an ROP screening program in one place is not the same as setting up in a different country or different region, right? If you've seen one program, you've seen one program, and there are a lot of different considerations around that. Data management still continues to be a challenge, and I think that we have to have good data at the end of the day, and we have to have integrated solutions, which then brings in the whole PHI issue and security. So making sure that across all levels, we're protecting the patient and their confidentiality, software compatibility, and of course, one of the big issues that I think we need to discuss is service. So, okay, great. We can create these solutions. We can create cameras. We can create software platforms. Okay, but if something breaks down and we're highly dependent on these solutions and we don't have the support to maintain them internally, then things break down. So we have to make sure that we create a sustainable infrastructure with the human resources and of course economically, as Dr. Campbell and many others mentioned, in order to make these work in the long term. So thanks again for having me. I look forward to the discussion. Go to the next slide.
Thank you very much, Dr. Chan. And then, yes, we're just going to hand over directly to Nigel Bolster to talk about peak vision.
Thanks, Aisha, and good day, everyone. Thank you to NEST360, UNICEF, Claire, and Becca for inviting me to represent Peak Vision in today's webinar. Peak Vision is a small UK registered not-for-profit with about 40 employees based throughout Europe, Africa, Asia, and North America. And we have a vision and mission of achieving vision and health for everyone. We originally started out as developers and manufacturers of both hardware and software eye health diagnostic devices, and one such device was Peak ROP, which I will talk about today. However, it's worth saying that the main thrust of our work now revolves around cloud-based software solutions for community and school eye health programs in low and middle income countries. And we presently support programs in 8 countries of this type in sub-Saharan Africa and South Asia, with a nationwide school eye health program about to launch in Botswana. But as I say, prior to this, while we were still exploring where our contributions to the sector was likely to be the greatest, we developed Peak ROP, which is a very low cost, wide field ocular fundus camera designed for ROP screening by non-specialists. And this work was funded by Standard Chartered Bank Seeing is Believing program. Next slide, please. Our core aim during the development of the camera was to really see how low we could go in terms of price and how far we could drive down the price whilst keeping the ease of use, field of view and image quality acceptable for ROP screening. This led us to designing a camera which images whilst in contact with the cornea via a coupling gel. The unit is about the size of a large market pen and is disconcertingly light, so you're not required to suspend a large heavy unit of a small, delicate, premature baby. The main reason it's so light is because the unit is powered by USB, meaning there's no internal battery, which also has benefits for transportation and shipping of the device. The camera has a depth of field which covers the full range of axial lengths which could be encountered, so no focusing is required. The field of view is equivalent to approximately 52 degrees subtended angle. However, owing to the weight and size of the camera's position on the cornea, the camera can also be adjusted with relative ease around the cornea to image further to the periphery. We produced a number of prototypes for design for manufacture based on these principles. The manufacturer cost of the design was approximately $275 US, meaning we would expect the end user costs of such a device to be no more than $2,750 US per unit. Next slide, please. However, as many of the other speakers have said, there are substantial challenges in developing low-cost ROP imaging solutions. And we certainly encountered challenges in the course of the Peak ROP project. The first is that despite the small size of the unit, we found that there was still difficulty in achieving good corneal coupling with the smallest preterm eyes. Further design enhancements allowing the tip to be narrowed would therefore be a probable next step for subsequent design iterations of the device. Poor coupling means increased corneal reflections. However, we also found that reflections from the crystalline lens caused a visible artifact in our image, and that's despite attempts at filtering these in hardware. Improved filtering, including software filtering, is therefore something that ought to be looked into next. We were also very conservative when it came to setting the safe range of possible illuminations. What we actually found was that the illumination was fairly dark, particularly in darker retinas. And so what we suggest looking for in subsequent design iterations is if that illumination level can be safely increased. All these challenges ultimately combined in producing an image quality which we feel can be improved upon. Image quality is the challenge for a low-cost ROP camera. A further design iteration may very well show that sufficient image quality can be achieved for such a low-cost device. Either way, we hope that Peak ROP represents a challenge to the industry regarding what can actually be achieved using low-cost components. Finally, the primary challenge we face as an organization in further development of the very low-cost ROP camera is Peak's organizational focus. As I mentioned at the top, we have moved away from the development and manufacture of eye diagnostic hardware towards software supporting large-scale community and school eye health programs. We have therefore come to the conclusion that our small team is unlikely to be best placed to continue to make advancements in the ROP screening space. We are, however, very keen to work with other organizations who are better placed to take the technology we've developed towards clinical use and contribute to the reduction of global childhood blindness. If you're on the call today and think that your organization might be interested in this, then please do get in touch with me after the webinar. I'd like to thank the PEAK team and White Blue Limited, who were involved in developing PEAK ROP, and also to Claire Gilbert and Pete Campbell for their advice and expertise throughout the development process. Finally, thank you for listening, and my personal thanks to all the other contributors today for their inspirational talks as well. Thank you.
Thank you very much, Nigel, for that great talk. And thank you very, very much to all our speakers for giving their really very kind of exciting and cutting edge, sharing some of their very exciting and cutting edge work with us today, and really trying to address some of the challenges of facing scaling up ROP screening. So thank you again for taking the time to be here. They're all going to be part of our panel discussion, which we're going to go into. But just before we do that, I'm just going to summarize the last of our poll questions. This was aimed at product developers. And the question was, what is or are the greatest challenges you face with developing an imaging technology for ROP? Again, this was a multiple choice question. And so right at the top, by far was cost, which was there at 56%. Joint second was technical complexity at 25%, and also infrastructure at 25%. And that was followed by limited market size at 17% and regulatory approval at 13%. So the top three there were cost, followed by technical complexity and infrastructure. So on that note, I think I will also wanted to mention that Phoenix Icon are on our webinar call today, and just to welcome and thank them for also joining us. And now I'll just hand over to Claire, who will start our panel discussion.
Thank you, Aisha. And please, this is now a time when you can put your questions into the chat box, please. And Becca and colleagues will be looking at those questions as they're coming in, and then we'll be able to target them to the most relevant panel member for discussion. Before I start on my first question, I have a question for Paul. And I was just wondering if you could provide a few more details about the actual technology that you're developing. You mentioned that it uses pars plana illumination. So does that mean that you have to use both hands, one hand holding the imaging device and another hand holding the illumination? How does it actually work?
Yeah, so this goes into the technical challenges, Claire. So right now we're in a state of clinical validation and streamlining the product. So right now it's, it works with two hands, which, as we know in ROP screening, is not the easiest thing to do. We worked with Pete on this too, just talking through it. We try to create a single device, right? That's just handheld, that's a contact, and then with the illumination on the outside. We've gotten some decent images with that, but that's one of the things that we're trying to streamline. So, one of the challenges, I think, and I'm coming from a different place in academia, right, where this development is actually occurring in the lab. And at this point, we've shown that it can work and it produces terrific images. Now it's at a point where we are saying, okay, well, how do we get this into a place where it can be commercially available? Right, so meaning streamlining the design so that it is a single handheld unit that provides pars planar illumination and give you that really, clear image. So from a technical perspective, yes, it's two. You have to use two hands right now. We're trying to integrate it into one sort of handheld system. And it's very, very small, right? So, we can go into some of the technical details around the fiber, but that's another discussion.
And very quickly, the advantages of the pars planar illumination is presumably to try and reduce reflections. Is that right?
Correct.
Okay,
Yeah.
lovely, thank you. So I now have a broad question to the product developers in general. And so following from the poll results, what do you think is the greatest challenging in developing imaging technology for ROP? And this will give you a bit more of an opportunity to expand on some of the questions, the responses you put in the poll. So can I start with KC first? So what were your greatest challenges and you had in developing NESTRO, and in wanting to make improvements? What challenges do you face going forward?
I think the biggest challenge, as I kind of listed, there are a lot of technical challenges like the size of the optics. It has to be light and all of that. And actually it takes a lot of time for development. It's like a 3-4 year development cycle, and the market conversion is also pretty slow, right? So you cannot just work on the product development alone. You'll also have to work on market development innovation. So when Dr. Paul talked about making a platform, so one of the critical things which you have also done is make this platform device agnostic also. So if you already have a red cam and you want to have a very stable system, you can kind of connect, which you've already done on the adult side. The other important challenge, what I feel is you have to get it medical grade, because these are all going to get into incubators and it can actually affect working of the other equipment there. So you have to have the highest level of EMI EMC clearance, and today the regulatory clearances in CE have become much more stringent than what they were. So passing the MDD and it's a compact device, so you also have to get the 510K. So it's a long process. So I would say combination of large development cycle and then achieving the right thing, repeatability. It's not just you make one prototype and it'll work. Can you consistently make this product day in and day out and it'll work the way you want? Can you limit the serviceability so that you don't have a problem? And ultimately, can you get the regulatory clearance, because every country has a regulatory clearance. So you have to kind of integrate all of that into your development cycle before you actually launch. Maybe you will go one after the other, but it should encompass. You can't change the design after just to meet a country's regulatory requirement because they ask for it and you're not meeting it. So those are typically the challenges.
Thank you. Thank you very much. Paul and Peter, you both work in a university environment. Casey works in industry. So are there any particular challenges of working in a university environment?
I feel like that's a loaded question.
No.
I think there are challenges, wherever you are. I think from our perspective, it's clear to what I mentioned before is, we can develop something, and what's terrific about, sort of what we've done is that we've shown that it works. The complexity here then, to Casey's point, it's the clinical validation piece, right? So getting something into the commercial space, right? So that you can actually test it, trial it, show that it works in the real world. And I think that's sort of a hurdle that we face. And, going through the IP process and all this other stuff. So there's a lot of different factors here, and I think Pete can talk about, the software side. But I think even from the PEDCAM side, this is what Dr. Yao mentioned, going through IP as well, is that sometimes that process takes some time because you want to get it out into the world so that people can use it. And then going through that process can sometimes take some time.
Mm-hmm. Thank you. Peter, do you have anything you want to add to that before we move on?
Just two quick comments. Two quick comments. In academics, we're always tinkering, right? We're always trying to make things a little bit better. And sometimes what the world needs is that next step of taking something that works and not trying to keep tinkering with it, but trying to actually get it out there and scale it. And that part is not something we're trained in academics, is how to overcome all of those implementation challenges. The second piece here is just to echo what a couple of other people have said, is that this isn't really a hardware problem, because as Casey knows, as RedCam knows, the cost of the materials of making any of these cameras is far less than what the companies need to charge in order to have a sustainable business. And so one of the challenges is creating a favorable economic system that allows low-cost devices to be made available at low cost. And that's a problem that we haven't solved yet.
Fine, thank you so much. Aisha, I'll now hand over to you.
Yeah, thank you, Claire. Yeah, I'm just going to go to some of the questions from the chat. And there's two actually for the Peak camera. So there's one about, does it store any images or is it used together with a computer, smartphone or tablet? And the second question for Peak was, what's the field of view for the Peak device? So I'll just get Nigel if you want to answer those.
Yeah, thanks, Aisha. Based on testing that we've done on a Model I, which is kind of like a known quantity, we approximated it's a 52-degree subtended angle in a single image, and then you can pan around the eye to see more. On the connection, it's connected via USB to either a laptop or a tablet, and that's where it draws power from. So it doesn't need to be connected to mains, and it doesn't have an internal battery itself. And also where it streams images and video too. We haven't developed a companion software application for the device, so we just have a development software application, not something that's connected to cloud storage or designed for entering patient details and things like that in it as well. We've just developed the hardware component of that and the kind of bare bones of what software is required to run that and test that.
Okay, great. Thank you. Thank you for clarifying that, Nigel. And we've got another question which is about smartphones, and it's how can we use it as a medical, I think that means device, without health system approval? And has anyone done this or done this process to get it approved? I think maybe Guillermo, you'd be the best place to sort of answer that question, because you've been using the smartphone devices for, I think, the most.
Yes, Aisha, we are going on with the validation, clinical research, and once the results and final analysis is ready, and with the conclusions, we will be ready to go on with the next steps, because the big question is, what can we ask to the smartphone in retinal ROP images? And this is what we're trying to answer.
Yeah, okay. So at the moment you are using it, but it's just that in terms of getting the approvals, you're still going through the process of it. Is that right? Am I understanding?
Yes. And by the end of the year, we will have the results.
Right, great, thank you. Now just looking a couple of more, and then there was a more general question about how can we make these technologies available in developing countries, given the cost challenges prevailing in these countries. That's quite a general and big question, actually. Anand, would you want to sort of answer that? Is that something that you've been thinking about, I think?
Thanks, Aisha. Well, making it affordable and accessible is, of course, the biggest challenge. And I think that's why we have webinars like this. But even as newer technologies are being developed, the existing technology can be, they can be hired in terms of the subscription model. So people don't have, the majority of the problems that happen here when new centers want to start ROP screening is they don't have enough CapEx, but they somehow can make it run if they have the initial capital to buy the camera, because the device ends up paying for itself if you charge the patients. Of course, in a charitable mode, even that is difficult, but assuming one gets the camera, usually it pays for itself within about 18 to 24 months. And I'm talking about the Neo camera, and because this has been experienced from Indian users across, sometimes even earlier, depending on how many centers they screen in. So then their real problem is funding it initially. So I think if companies get into the subscription model, sort of give it out for rent and charge a per case. And for companies, I think to make this, monetize this, if they have, like Casey said, a platform that not only provides the device, but also AI and a sort of a triaging diagnosis, then, well, the company can also earn a recurrent income. Because for them, they just sell the device and then they don't earn anything out of it. But if they have the AI model with it, and then with that, the triaging, then it could be a win-win for both parties. That's one way you can, before even lower cost technologies are developed.
Great, thank you. I think I had one, there's still more time just to all the participants, just to mention that to ask more questions within the chat box, but just while you're putting a few more in, I had another general question about ease of training. This is to, again, different members of the panel, but just to kind of ask you what you think in terms of the different devices you've used, which ones are easier to train, basically, non-specialists in, ophthalmologists in. Actually, this might be a question again for you to Anand to start with, and then maybe Paul can also answer as well. But in terms of comparing different devices and training people to use them, how do you think they compare?
Well, the Neo and the RedCam are almost comparable. The Neo is probably easier because it's more portable and there are fewer movable devices in terms of the lens getting detached. And our training curriculum has really evolved in the past 15 years. Initially, and in our initial publications, we said level 1, level 2, and level 3 technicians, based on their skill and their speed and their accuracies and their ability to image the ora serrata, because that was a prerequisite before you discharge the baby. Well, that has really changed, because from 30, 60, and 90 working days that we used to take to train one person, we now just expect them to spend about 7 to 8 working days with us. And the rest of the training is actually online. So and this started even before the pandemic. So they go back to their neonatal centers, and our resource people connect with them and watch them do it, correct their stance, their position, help them, troubleshoot them. And all of that can be done online. And a lot of the study material is online as well. So we actually have an online platform to do this. And we piloted that in our own state, and then 2 other states in India, along with the government. So, and it's working pretty well.
Great, thank you. Paul, was there something you wanted to add to that as well, comparing some of the devices you've used across?
Yeah, I mean, to Anand's point, I think that when you look at the Forest, now the RedCam and also the Icon, it's all about the same, right, in terms of the ease of use and training, and it's a steep learning curve. I think one of the things that Anand touched on is that, you still have to invest in the local human resources and infrastructure there. So, having local expertise is really, really important. In the programs that we've worked in, Leslie McKean, who I think is on the line, she's always been with us to train the local partners. And then again, to Anand's point, we've maintained, sort of this connection through sort of telementoring to make sure that the quality of imaging has been good. But I think I can't stress enough how, when you look at different countries, India, with KidRop and also with the Aravind system and Rop SOS, they've done really well in training the technical staff. There are challenges though, depending on where you go, right? So you have to make sure that you're investing in the local talent. And that's very variable. But, systems like Anand and so forth, where they have this training platform, those are very, very useful.
Yeah, that's a good point. And I think also the point you made about the tele-mentoring and having a system to continue mentoring people after they've been trained is really important. And that was something when we did our ROP network and we had all the different countries being connected and trained and they had South-South connections, it was really useful, because then even after the training, there continued to be a connection where you could ask questions, because really the learning curve continues for some time.
Yeah, and it's, we're all so used to this now, right? It's like we're used to just talking to each other at screen.
Yeah.
It's fine.
Some of the positives of COVID, yeah. I also just wanted to ask a question to Christoph, if you would like. It was just about, in terms of, moving forward, if different groups or people are developing ways of evaluating these new systems and new products. How does UNICEF see it? Does it have any role in kind of, I think, overseeing or reviewing or being part of evaluations? Would it be something that would be interested, or how would they, I suppose, get involved further along the lines in terms of this sort of further development of new products or systems?
I mean, our processes that are public procurement, right? So if we move ahead with this, eventually we'll run a tender, and then there'll be a structured process around this. We might also have these, as I mentioned during my talk, industry consultations, if we deem it's not a small thing. So it's a big effort to do, but if it's important enough, we can set up such a thing, which is a formal event for people to engage and collaborate and get clarifications. Historically, when we had TPPs out, we've had ongoing dialogues with companies, as I said, to sort of get the aspect both ways, i.e., so for us to clarify anything that might not be clear from the TPP, or for us to get information on needs for the TPP to be updated due to the collaborative nature of this stuff. It might work a little different around it, but once moving ahead, there is an opportunity to engage. I think sometimes, the value of UNICEF in these aspects is our ability to look at needs from a global aggregate perspective, right? So in terms of getting really in-depth discussions on specifics around the technology, I'm sure there's others throughout this call that are potentially better at that. So our angle will be more looking at that, will be from that procurement in the end, i.e. once sort of starting to send signals of this is probably how we're going to structure this tender, and that kind of stuff within the degree we can do that, given we're operating under strict public procurement guidelines. It's a bit of a vague answer. I hope it clarified some.
Yeah, thank you. Thank you very much for that, Christopher. I'm just going to hand back to Claire now, just to kind of round up our panel discussion.
Thank you very much, everybody, for this discussion point. And I'd have a very quick question for Guillermo about whether it's possible to train non-ophthalmologists using the indirect with the attachment. Is that possible?
We are working on some telementoring projects, but we need to improve the infrastructure with high-speed internet connections. We are starting some trainings at distance with simulation and it's going good. We are starting this first step of the training in Argentina. Maybe we can work in collaboration with some other regional countries. So we will let you know soon, maybe.
Thank you. Thanks, Guillermo. And now I shall hand back to Becca for her to make some final comments. So thank you very much, everybody.
Thank you so much again to our impressive panelists for sharing your experiences with us today. So as we've mentioned, this webinar really kicked off the process for developing a target product profile for the screening and diagnosis of ROP in neonates in resource-limited settings. So we wanted to share on the next steps. We did hear from Christopher earlier that the ultimate target product profile that we're creating will be available on the UNICEF website, and an example of a phototherapy TPP, which we developed, was sent around for reference to give everyone an idea of what we are working towards. So for the ROP TPP process, we're really following a systematic process. So over the past year, we've reviewed with stakeholders to identify the different needs and challenges that users face. we worked with a group of ROP experts to develop an initial draft and defined minimal and optimal characteristics. Rather than simply distributing that survey directly, we decided to host this webinar to convene leading experts around the globe to discuss the challenges faced with existing technologies and opportunities for innovation that we've heard about here today. So our hope is that this webinar really helps to foster those connections and a really communal sense of ownership of the ultimate TPP that we're hoping to develop. So the next step, as I said, we are here on this webinar. So I will be sending out a link to the online survey. So we ask for you to complete that online survey. It will take roughly 20 to 30 minutes to complete. You will be asked to rank a list of performance and operational characteristics, which again, we've worked with ROP experts to define that initial draft. This survey is going to remain open until October 8th. So please submit your responses by then for your feedback to be incorporated. The final step of the process is to host a virtual workshop, which we will host on November 10th at the same time as today's session, so 1 to 2:30 p.m. Universal Time, if there are outstanding areas of disagreement based on the online survey. The goal of that workshop is to achieve consensus, and a report will hopefully ultimately be published in early 2022. So a quick summary with the key dates to remember is to complete the online TPP survey by Friday, October 8th. You will receive a link to complete that survey from me. And based on that feedback, save the date for November 10th in case we do have to convene the group again to discuss areas of disagreement. As for last words, I'm going to pass it off to Professor Claire Gilbert, but thank you everyone for your time and joining today.
Well, thank you. It's up to me now just to thank everybody from the organizers, the panelists, and you, the participants, for taking part in this really important webinar. And as we heard from UNICEF, that these TPPs can really make a difference in producing technology that really addresses a recognized need. And I think the very fact that so many participants are on this webinar is acknowledging the fact that there really is a big need for innovative technology so that screening for ROP can not only be scaled up, but can also be of extremely high quality. So we're now about halfway through the process, and I do encourage you all, please, to complete the online survey, and you will get the link from Becca. And then we look forward to having a TPP published and available and in the public domain later in the year or early in the new year. So my thanks to everybody, and enjoy the rest of your day. Thank you.
Thank you very much.